What's up, everyone? Um, First and foremost, I want to thank everyone in here for donating towards the fires in California for the Los Angeles Fire Department. Uh, we were able to raise a good amount of money, so I'm super happy. And with that, we were able to help out whatever we can. So whatever we can do here with the Hood Boy Family Foundation and NCLEX High Yield. Obviously, Hood Boy Family Foundation is my nonprofit with my family. So it is a 501c3 nonprofit. So you did donate directly. Everything, 100% of what you donated does go directly to the LA Fire Department. So be very happy that you contributed and you get to learn at the same time. So with that said, we're going to do Farm Power Hour. Typically, you know my teaching style. Most of you know my teaching style where I break things down on a level where you understand. I'm not about memorization, right? I always want you to understand certain things. But today, what we're going to do is we're going to do this Farm Power Hour where we're going to do a rapid review of drugs. I'm going to try to get through as many drugs as I can where where we're able to see what these drugs are labeled, what they're used for, what their side effects are, maybe what their contraindications are. We're going to literally power through boom, 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 boom. It's going to be a rapid fire type of a session. Something I haven't done before, but I wanted to try it out because what the consensus has been is pharm is a tough subject for most students. The first thing I'm going to start off with before we even get into the drugs is the 6 ways that the boards can ask pharm questions. There's only 6 ways. That's it. So when people see pharm questions or pharm drugs, they get intimidated by the idea of pharm, but there's only 6 ways I can ask you a question on pharm. On the boards, they're going to ask you to identify it. So what is this drug? Do you know if it's a statin, if it's a beta blocker, so on and so forth? Do you know if it's an SSRI? Identify the drug, point blank. The second thing is its side effects. So if I'm dealing with the statin, rhabdomyolysis, okay, it's a side effect. Boom, that's it. Then we could talk about contraindications. For instance, taking a beta blocker with an asthmatic patient. Not going to happen. Then we're going to talk about dosages. If the boards ask about dosages, not very high yield, but there are drugs like atropine, adenosine, things of that nature, where we do talk about dosages. Education, the do's and don'ts. For instance, eat consistent green leafy vegetables when taking warfarin. Education. Bleeding precautions. Education. And the last one, if there's an antidote, know the antidote, i.e. heparin, protamine sulfate, warfarin, vitamin K. So there's only 6 ways that the boards can ask questions: identification, side effects, contraindications, dosages, education, and antidotes. That's it. So now let's get into some drugs. The first section of drugs we're going to talk about is cardio medications, cardiac medication overview. So many of these you're familiar with, but I'm not going to skip any of these because they're super high yield. Cardio being one of the biggest subjects, the pharm associated with it, of course, high yield. So beta blockers. This one has a suffix. Not all drugs will have a suffix, especially when you get into mental health. But in cardio, we're fortunate to have a suffix. So what do I mean? The end portion of the name of the drug. So beta blockers end in LOL. Example, metoprolol, atenolol, propranolol. So identifying the drug with that hint of LOL, well, that lets you know. What are some indications for beta blockers? Well, we can use it for hypertension, angina. We can use it for hyperthyroidism. We can use it just in general to control the heart rate and blood pressure. But if I'm going to control the heart rate and blood pressure, what could be a side effect of it? Well, low blood pressure and low heart rate. Some other side effects that we can deal with when we're dealing with beta blockers is we're worried about bronchoconstriction and bronchospasm, which means that I have a clear contraindication. If a patient is an asthmatic patient or a COPD patient, we are not to prescribe beta blockers. Monitor their heart rate, monitor their blood pressure. Keeping it simple. Moving on. ACE inhibitors. ACE inhibitors end in pril. So the most common one you'll see, probably lisinopril, enalapril, captopril. And they're used in, again, hypertension predominantly. Are there other indications? Yes. But the mnemonic is ACE-I for the side effects. Angioedema for the A, cough for the C, E is excess potassium, and I is instead use an ARB, which ends in sartan. Well, angioedema, cough, excess potassium. So what am I going to monitor? Well, I'm going to monitor the potassium levels. It is metabolized by the kidney, so I'm worried about the renal function. So excess potassium. I'm going to worry about their breathing or swelling of the face, swelling of the lips, swelling of the tongues, because that becomes ask graph. It becomes a prioritization question. The cough is a nagging cough, a nighttime cough, a hacking cough. It's not airway, it's just annoying. So the I in ACE inhibitor is instead switch them to ARBs. ARBs end in sartan. Again, used for hypertension predominantly. But this drug, and if you've ever seen me teach the renin-angiotensin-aldosterone system, the RAAS, you'll understand why potassium goes up. So if you want to review that. It's a great way to understand why these drugs affect potassium. So the side effect in this one is hyperkalemia. So if I have an ACE inhibitor that causes excess potassium, instead I'm going to use sartan, but only if it's angioedema and cough, because both can cause excess potassium or hyperkalemia. Both of these drugs, ACE inhibitors and ARBs, are contraindicated in pregnancy. Contraindicated in pregnancy. The next set of drugs is one set of calcium channel blockers. And this one is the one that ends in dipene. Amlodipine, nifedipine, nicardipine. Again, things like hypertension, coronary artery disease, angina. But they are vasodilators. And if they're vasodilators, hence why we use it in coronary artery disease or angina to get that blood flow going, then it's not just going to work on the coronary arteries, it's actually going to work systemically. If it vasodilates systemically and they're on it for an extended period of time, that blood, when we vasodilate, is going to vasodilate in the periphery, and well, gravity is going to eventually work. So that blood is going to pool because of gravity and that vasodilation. We're going to see peripheral edema. Because it can decrease blood pressure, we're worried about hypotension. Any drug that's used for hypertension, we're always worried about giving too much and the side effect being hypotension. So if we're using it for something and we use it too much, it can cause the opposite effect. Calcium channel blockers are one of those drugs that you avoid grapefruit products or grapefruits in. I always tell my students, make a list of drugs where grapefruit affects the metabolization of that drug, because you have to educate. Remember, I said one of the 6 ways that you can ask a pharm question is, in fact, education. So you must educate them to avoid grapefruit products. So make a list of the ones with grapefruit being contraindicated with it. Then the other one is make a list, or if you have our quick tip book, or if you know the quick tip on one of our social media platforms, it is in fact Tirado-Wa. Tirado-Wa. So the mnemonic Tirado-Wa, you can look it up. It is on pretty much every platform of ours and in our quick tip book. Those are the ones that are contraindicated in pregnancy. So teratogen, Tirado-Wa. Antibiotics. So the first one is penicillins, Endocrine, amoxicillin, piperacillin, penicillin. When do we typically use it? Well, it's a broad spectrum antibiotic. So infection, gram-positive, gram-negative, strep, respiratory infections, skin infections, we can use penicillins. But the biggest thing that the boards are going to test on when it comes to penicillins is allergic reaction. And it's not just an allergic reaction, it is in fact an anaphylactic reaction. Why do we find out that we're allergic to penicillin? When do we find out that we're allergic to penicillin? And why does everyone find out at some point if they are or are not allergic to penicillin? Well, as we're children, we're prone to getting sick. Guess what the first line is? Our first line of antibiotic that we're going to give a child, the first infection that they get, we're going to give them a penicillin. So those of you that remember when you were kids, it was that pink little bubblegum tasting syrup. That was your penicillin. That was your amoxicillin, to be more specific. But that's our first line. In a first line drug, the first time we give it, are they going to have an anaphylactic reaction? No. The first time we give it to them, they're going to develop hives. They're going to develop itching of the throat, swelling of the throat, trouble breathing, but it's not an anaphylactic reaction. It's an allergic reaction, indicating to us that, whoa, this person is allergic and is anaphylactically allergic to penicillins. So when you see the question on the boards, when you're going to see it, it's the first dose. The first dose that you receive is going to be indication that you're anaphylactically reactive, and it has to be hives, swelling or itching of the throat. If I get a skin rash or I get a little diarrhea as a child, is that going to indicate that they're anaphylactically reactive to penicillins? No. So again, further teaching, further intervention. Oh, you know, the first time I got it, I got hives and I got, you know, itchy throat, but I could probably take it again and I'll be just fine. No, absolutely not. Further teaching, further intervention. The next thing is GI upset. I always say this. It's not 100% going to be true for every single drug, but if you think about it, if you're taking something orally for the first time, or you're taking something orally that you're not used to, chances are if you have any type of reaction, it could be GI discomfort, nausea, vomiting, diarrhea, stomach pain. So typically with oral drugs, if we see a reaction, don't be surprised that just select all that apply. It could be nausea, vomiting, diarrhea, stomach upset, stomach pain, because we're taking something orally. And especially when it takes a toll on us, or we're taking it for the first time, or we're taking it for an extended period of time. The next antibiotic is your cephalosporins. With cephalosporins, again, we can use them for respiratory infections. We can use them for strep. We can use them for a bunch of different infections. But what we're concerned about, what the boards are going to ask about, is that cross-reactivity with penicillins. 10% of people with anaphylactic reaction of penicillins, cephalosporins are going to react as well too. So are we going to give a cephalosporin to a person that's anaphylactically reactive with penicillins? Absolutely not. That's a further teaching, further intervention. That's, again, education, one of the 6 ways that the boards can ask the question. The next one is macrolides. The most common one that we're going to look at is azithromycin. So what do we know that as? Of course, I don't want you to know the brand names or what it's like, what the lay terms are, but we call it a Z-Pak, azithromycin. And it's great for respiratory infections. And we may need to use it for STIs. GI distress, yeah, absolutely. Of course it can cause GI upset. But the one that we're worried about is QT prolongation. QT prolongation. If you watch my EKG videos, the QT interval is what part of the heart? It is, in fact, the ventricle, which means if I'm prolonging it, can I throw it into a dysrhythmia? Absolutely, I can. And if I'm prolonging the QT, that dysrhythmia that I'm concerned about, ventricular fibrillation. Ventricular fibrillation. So of course, if we feel any dysrhythmias, we're going to monitor them on EKG. And if there's any side effect with any drug, remember what I always say. Stop the offending agent. Stop the offending agent. The next one is our tetracyclines. Most common one that we're going to look at is doxycycline. So doxycycline, monocycline are going to be the ones that you're going to see. Very common in acne. Very common in acne. But it's a tetracycline. So what is a mnemonic? What is a quick tip? SAT for a photo. SAT for a photo. Sulfa drugs, S. Amiodarone, A. Tetracyclines, T. Fluoroquinolones, F. SAT for a photo. Photo meaning photosensitivity. So if a patient is on a tetracycline, what are we concerned about? Photosensitivity. With photosensitivity, we must educate our patients. Again, with tetracyclines, one of the 6 ways I can ask a question, SAT for a photo, educate them on photosensitivity. So things like long sleeves, wearing a hat, sunscreen, avoiding the sun. These things are education, education, education. This is a teratogen. So are we going to take it in pregnancy? No. Avoiding pregnancy. Why is this a really good one? So let's think about this. When we're talking about doxycycline, we're talking about acne being an indication. We're talking about STIs being an indication. What population does acne and STIs indicate? A sexually active, potentially sexually active, or asexually active population. Which means in the female population, And remember what I say, if they say urine pregnancy test, if they say, when was your last menstrual cycle? If they ask for HCG level, if they ask that you're sexually active, why did they put that in the answer choice? Well, in this drug, especially, not, and obviously the other drugs where pregnancy is contraindicated, in this particular drug, tetracyclines, you've got acne and STIs. So maybe teenage or above population with acne, they could be sexually active. STIs indicates that they're sexually active. So in a female patient with acne, female patient that is sexually active, we must ask and we must educate to avoid in pregnancy. Avoid in pregnancy. And fluoroquinolones. Fluoroquinolones. So what is our fluoroquinolones? Ciprofloxacin, moxifloxacin, levofloxacin. Where are these indicated? Respiratory infections, UTIs. Is this first line for UTI? No, it's not. Cipro is an excellent drug for UTI, commonly used for UTI, but it's not first line. So fluoroquinolones, again, with the mnemonic SAT for a photo, so educate them on photosensitivity. But a nasty side effect of extended uses of fluoroquinolones is it can develop a tendon rupture. What tendon are we scared about that takes a long time to recover? Those of you that watch sports will probably recognize this, or even if you don't watch sports, will know this. What is the one tendon that we are scared about rupturing? Our Achilles tendon. Our Achilles tendon, yeah. So with the Achilles tendon, if it ruptures, those of you that have watched basketball, football, you're talking about season-ending injuries. So if that's for an athlete who's probably in the best shape, imagine how long it's going to take for one of us to recover. And with all drugs, if they cause GI upset, nausea, vomiting, diarrhea, do you think it's common for the patient to be like, oh, I'm going to go ahead and take some bismuth salicylate or Pepto-Bismol, or I'm going to take some Tums, or I'm going to take some Rolaids, antacids? We must educate these patients. Do not take antacids prior to taking this medication. And if you did take an antacid, how long am I waiting before I take my medication? 2 hours. 2 hours. Imagine what the boards are going to ask. Think about this. Drugs, commonly I said, can cause GI distress. Patient's going to go into local pharmacy, is going to look at GI upset or GI distress drugs, antacids. Oh, it's going to help with my not indigestion, but my nausea, vomiting, diarrhea. And lo and behold, they decide to take it, and then they pop their medication with it. Is that medication going to work? Not to its fullest potential. Not even close. Does that mean things like proton pump inhibitors? No. Proton pump inhibitors are different. PPIs are different. Our prazols are different. I'm talking about our antacids. Antacids, the ones that instantly change the pH of our stomach, making it more basic, more alkalotic, decreasing the acidity, changing the entire way that we break down medication. Let's move on. All right. So this is one that I typically don't cover as its own subject. I cover this individually as we see drugs. And this is high yield antidotes. And the common ones that the boards are going to ask, the most common one that the boards are going to ask is probably opioids. And we talk about this in mental health because opioids are going to cause respiratory depression. Not only respiratory depression, a lot of people are going to combine this drug with alcohol, or they're going to overdose on it because they take too much of it, and or they're abusing not only a prescribed version of it where they're taking too much, or they're going to a street version like heroin and they're taking too much, overdosing. Why? Opioids build tolerance. And as you get tolerance like this, you need your fix even quicker and quicker, and you need more and more. And now you're taking such a large amount that this drug that causes severe respiratory depression can literally kill you. So now, what do they offer for free at pharmacies when you get an opioid drug prescribed to you? Naloxone, which is Narcan, naloxone. So the big one for opioids, naloxone, antidote, huge because we see so many people passing away from opioid overdose. The next one is acetaminophen. Well, again, acetaminophen, brand name Tylenol, acetaminophen over the counter. Well, what is our max dose over a 24-hour period? It is in fact 4 grams or 4,000 milligrams. 4 grams or 4,000 milligrams in a 24-hour period. Why is the antidote so important for acetaminophen? Because it's over the counter. Each pill typically you can see is going to be 500 milligrams. 500 milligrams, and it tells you to take 2 pills at a time, which means you're taking a gram. How many times can you take that dose? Well, a little med math, you can take it 4 times in 24 hours, which means you can take it every 6 hours, max. Not 4 to 6 hours, probably 6 to 8 hours. But the reason why we're concerned is that people that are in pain, people that have fevers, people that have suicidal ideation can overdose like this, especially in suicidal ideation. If somebody has suicidal ideation, they can go to the cabinet, take a handful of pills at 500 milligrams. Let's do a little bit of math. I'll slow down here real quick. We got 4,000 milligrams in 24 hours that we can take before it becomes overdose. If each pill is 5,000 milligrams, 4,000 divided by 500 is how many pills in a 24-hour period? 8 pills. That's it. If somebody takes a handful or 2, do you think they've exceeded 8 pills? 100% they have. Suicidal ideation. So we must give them their antidote within 8 hours of their overdose. And the antidote is, in fact, acetylcysteine or N-acetylcysteine. Acetylcysteine or N-acetylcysteine. The next one is benzodiazepines. Again, another mental health drug because we prescribe it for anxiety. And the one thing that we've learned is that the world is anxious. The world is anxious. Students are anxious. People taking the NCLEX are anxious. Anxiety is all over. So benzodiazepines, obviously not the first line anymore. What we try to do is what? In mental health, always think about, before we give a drug, For anxiety, what do we do first in mental health? Before we give a drug, we always do cognitive behavioral therapy, CBT. Then we move on to a newer drug that's prescribed for anxiety, which is buspirone. Buspirone takes about 2 weeks to get active. So educate your patient. Hey, it's not going to work right away. So give it some time. Another alternative is an SSRI. So we have alternatives before we get to benzodiazepines, but benzodiazepines are fast acting. Similar to opioids, they cause respiratory depression. Now, the thing about benzos and opioids is you can build tolerance to both of them. Which means that if I'm popping one pill, it'll work right away. And I'm like, oh, I feel great. The next time it works, the next time you get anxiety, you take it, it's like, it's not working. Oh, let me take another one real quick. Oh, okay, it's working. And now we're talking about people that abuse it. They may combine it with opioids. They may combine it with alcohol. Because when we take alcohol or when we drink alcohol and we're removed from alcohol, anxiety levels go up. So what do? Pop a benzo. Well, then they're going to drink again. Then they pop a benzo. And now maybe they're combining the two. Respiratory depression. The other thing that benzodiazepines are used for, think about lorazepam. Lorazepam, brand name Ativan. Lorazepam. When we think lorazepam or Ativan, again, Ativan's a brand name, but lorazepam, what do we think about? Seizures. We use it for seizures. If somebody's having seizures in the hospital, we are giving them lorazepam. Give them 2 milligrams, 4 milligrams. Give them lorazepam while they're seizing. Which means if this drug decreases seizures, if I take this drug for a long time and I rapidly remove it, guess what's going to happen? A seizure. If it treats seizures and I take it away, the seizures come back. So again, we must educate our patients not to abruptly stop, but to taper off. But the antidote is flumazenil. Flumazenil. Another common antidote is warfarin and vitamin K. Warfarin and vitamin K. And the next one related to it is heparin and protamine sulfate. So I always say, when it comes to the antidote of these two, if you know one drug, by default, you know the other. Make a column. If you're taking notes right now, make a column. Put heparin in one column, put warfarin in one column. Heparin. What do we call heparin for short? Hep. How many letters in hep? 3. How many letters in PTT? 3. Hep. PTT. Antidote, protamine sulfate. So hep, 3 letters. PTT, 3 letters. Protamine sulfate with the P. So hep, PTT, protamine sulfate, you got the alliteration. Which means by default, I should know warfarin. So if heparin is PTT, warfarin by default is what? PTINR. If hep, PTT, protamine sulfate is the antidote for heparin, by default, I should know warfarin as vitamin K. Don't mix them up because I can almost guarantee you somebody is going to see this, if not many of you, if not you've already seen it before, because they're super high yield drugs. Super high yield drugs. So antidotes, endocrine medications, oral hypoglycemics, The first one, the most high yield one, is going to be metformin. because we can cause lactic acidosis, but what about this drug do the boards love? You are going to stop this drug before you get contrast dye. Stop this drug before you get contrast dye, but for how long before? The time frame, educate them. It's going to be, in fact, 48 hours. 48 hours. Well, if they're getting contrast dye, we hold it for 48 hours. We get their contrast dye. When we get the contrast dye, what are we going to do? Aggressively hydrate, and monitor what? BUN creatinine, their kidney function. And then when can I start them back on their metformin? 48 hours after. So 48 before, 48 after. 48 before, 48 after. The next one is sulfonylureas. And these can cause hypoglycemia. This is where I say ask graph. Glucose less than 70. A patient, again, takes too much of it, glucose level, and they're going to say glucose level below 70. Or they're going to say a patient tried to do what? Again, going back to mental health, suicidal ideation. They took a handful of a sulfonylurea. And now they're becoming severely hypoglycemic. Ask graph. It is one that we're freaking out about. Obviously, in this drug, it says sulfa. There's sulfo in the beginning of it. So again, sat for a photo. Sat for a photo. The next one is our thyroid medications. Our thyroid medications. So things like levothyroxine, propylthiouracil, or PTU. With levothyroxine, we are replacing our thyroid. So what have we done? Maybe we've done a thyroidectomy. Maybe we've done radioactive iodine. Not the uptake, but radioactive iodine, where we try to burn it out. And we're not making our T4 anymore. So we give them levothyroxine. What are we going to educate them on? Take it first thing in the morning. Again, one of the ways that we're going to ask this question. Take it first thing in the morning on an empty stomach. And well, if I'm giving them thyroid replacement, I'm going to monitor their TSH T4 levels. TSH T4 levels. If you have a thyroidectomy, or if your thyroid is gone, it is a lifelong drug. Now, the thing about thyroid drugs is there like a standard dose? Like, oh, here's X amount of micrograms. Here you go. It's not. So you must educate your patient that we must monitor their blood, and depending on the endocrinologist, however, like 3 months, 6 months, depending on how under control it is. So again, how often, Dr. Z, how often are we supposed to monitor them? It becomes a depends question, because people react to different dosages, have different maintenance, and the endocrinologist will determine how often to monitor that. With propylthiouracil and methylmethoxazole, propylthiouracil, PTU, or methylmethoxazole, we are concerned about using this for hyperthyroidism. Because we're not going to go straight to doing radioactive iodine. We're not going to go straight to a thyroidectomy or a partial thyroidectomy. We always go from least invasive to most invasive. In this situation, we do have 2 drugs, and we are concerned about pregnancy with both of these drugs. So monitor their liver function, along with, if they're pregnant, make sure you're using the right one in the right trimester. I talk about that more in detail in our thyroid lecture. And the last one in endocrine is steroids. So the big one is prednisone. Prednisone, corticosteroid. Where do we see cortisol levels? What do we see as too much or lifelong prednisone? When do we use, let's use an example of this. How about chronic bronchitis, where a patient has chronic inflammation of their bronchioles? Their airway is chronically, lifelong affected by inflammation. I need something that's going to decrease inflammation. So can I give a steroid? Absolutely. Am I going to be on it for lifelong? If it's a chronic situation and we can't get over it, yes, absolutely. Or at least an extended period of time, which means that I'm increasing cortisol levels. So remember that mnemonic, a big fib. Excess cortisol levels. Endocrine lecture, knowing the adrenals, knowing cortisol. So the thing about prednisone is educate your patient on what? Are we going to abruptly stop this medication? Absolutely not. Taper the dose. Taper the dose. So what you'll see is when patients get prescribed prednisone for short term, for an acute situation, it comes in a pack where it's like 6, 5, 4, 3, 2, 1. They taper it for you because they don't trust you. So they put it in a pack for you. They're like, nope, we don't trust you. So take it this way, take it this way, take it this way. So that way we know you're tapering it off. And then again, monitor for a big fib. In the short term, look for hyperglycemia and infection. Remember, it is going to decrease our immune system. We are susceptible to infection, which means what are the common ones that the boards like to ask? Sore throat. It's just a sore throat. No. You're on prednisone. You're on a steroid. Then you've got a UTI. Oh, that's just a UTI. I get them all the time. Then you've got gastroenteritis. You've got infection. No, that's not normal. Not with you, not with the patient that's on a steroid, not with the patient that's on a steroid. Because we are susceptible to infection. So we are scared about, ask, graph, sepsis.